session of the fundamentals of orthopedics. Today we've got a session all about knees, and just a few housekeeping rules before we get started. Firstly, please do make sure you're muted, and please avoid annotating the Zoom slides. And I will now hand it over to Mr. Lucky J. Seelan, who is the chair of the Fundamentals of Orthopaedics group, to introduce our speakers. Thank you.
Hi everyone, thanks again for joining us. And thanks to our speakers who, as usual, are giving up their free time to help us out here. So I'm really grateful to them. And we've got three great speakers today. We've got our very own Sebastian Ho, who's an orthopedic registrar, and he's going to be running us through some of the fundamentals around knee trauma. Then we have a good friend of mine, Mr. Alex Charalambous, who has just returned from a fellowship in Toronto to talk to us specially about soft tissue knee injuries. And finally, it's a great pleasure to be able to introduce a mentor of mine, Mr. Satish Kuti. He's an orthopedic consultant from Harlow, lower limb specialist, and he is going to be giving us pearls of wisdom and knowledge on the fundamentals of the basics of total knee replacement. So without further ado, I'm going to pass you across to Seb, who I think is kicking us off with the trauma.
Yeah, hi. Evening, everyone. So my talk's going to be, let me just share my screen 1 second. So my talk's essentially going to be on the main bony trauma related to the knee. The main objective tonight is understand the main points of assessment when reviewing patients with knee injuries, identifying key risks of potential emergencies that might emerge in patients with high energy knee injuries, how to sort of the basics of interpreting knee trauma radiographs and common knee injuries, and sort of understanding the decision-making process that goes on for sort of regs and consultants when deciding when to do non-optive or optive management, and what are the different optive management options available when considering these cases. So first patient, 30-year-old gentleman, he's been in an RTA and he's driving a car, 60 miles per hour, crash, brought in by ambulance. He was wearing a seatbelt, but his knees did collide with the dashboard he was driving in. He was extricated by the fire service. He's conscious, complaining about pain in his right anterior knee. Ortho team has been called down to see him. So we'll just bring up the first question. What would everyone like to do now they've been brought down to A&E to see this gentleman? Can we bring up the first question, please? All right, I'll launch it there. Can everyone see that? All right, I'll pause it there and sharing the results. Yeah, that's great. So, I mean, they're not fine. They have been brought down. There wasn't a trauma call, but sometimes you can't trust what's happened between A&E department and them calling you. You have to make your own decision. You have to see this patient, do an AT assessment to make sure that everything is fine. This patient luckily is fine. They've got no life-threatening injuries, and you do proceed to get plain film radiographs, which demonstrates the above. So the first thing we're going to be talking about is patellar fractures. So they make up about 1% of bony knee injuries. The main mechanisms are either direct impact, such as dashboard injuries, where there's direct trauma on the patella, indirect, where the patella is pulled apart, such as sudden quadriceps contraction, or sometimes a combination of both. Now, the main thing why the patella is important is because it's an essential part of the extensor mechanism of the knee. If the quadriceps is essentially being pushed away from the knee's central rotation, and the patella serves to increase the moment arm of the quadriceps tendon, it is subject to eccentric load, which is going to come into when we do fixation for this. There's no fancy classification like with most fractures. It's purely descriptive in nature. So where in the patella is it? Is it the body, the apex, or the pole, up or lower? What's the pattern? Is it transverse straight across? Is it a vertical fracture, or is it blown apart? Is it sort of a stellate comminuted fracture? And then you want to know, is it displaced? Is it minimally displaced, or is it completely displaced? The fragments come apart completely. So your immediate management, ATLS approach. Pretty much all your trauma cases, if you have questions in the interviews, ATLS approach. Make sure it's an isolated injury, there's no life-threatening injuries. Check for any swelling, check for any tenderness. They'll be focally tender over the patella itself. And if it's particularly displaced, you may notice an obvious gap in between. Now, extensor mechanism, obviously, the main thing to do is ask the patient to try and straighten their knee. Some patients find it's too painful to do so. So your alternative, what I sometimes do is I get the patient to lift the leg up for them, and then I hold it straight, and I just see if they can just ask them to, even for a few seconds, just try and keep it up. Because sometimes if they can't even do that, then it's very likely, and it drops completely, then it's likely the extensor mechanism's gone. So the investigations that you normally go for, AP and lateral radiographs, sometimes a skyline if you're worried about a sort of vertical split through the middle. I immobilize them in a cricket pad splint, or you can put them in a above knee cast as well. I think cricket pad splint's the only thing necessary for this. And I usually allow these patients to fully weight bear, because of course you imagine the patella is not involved in the direct axial loading of the knee joint itself. So when do you do non-operative management? When do you do operative management? So the main reasons why you might do non-operative is if there's firstly an intact extensor mechanism. That's probably the most important. Is the articulus part of the patella where it's come apart, is it non-displaced, so it's completely together, or is it minimally displaced, so it should be less than 2 millimeters? Is it a vertical split pattern? So if you imagine the vertical split is not going to affect the extensor mechanism again, or is the patient medically unfit? They just are not fit for a haircut. They're not going to survive an operation. It's the risk versus benefit is not worth it. So in these people, you can do non-operative management. Now, these consist of mobilizing patients fully weight bearing, immobilizing them in extension 2-3 weeks. Now, that can either be in a cricket pad splint, one of these knee Zimmer splints, or you can put them in a hinge knee and lock them to 0 to 90 degrees in order to keep the knee straight, because you don't want to allow them to bend it and pull it apart. AO recommends not to ever put them in a cast. And I would monitor these patients quite closely in fracture clinic just to make sure that the fracture does not become displaced during this period of time. And after they've been immobilized, you can start slowly increasing their range of movement. What are the operative managements? Now, the most common one you'll see is tension band wiring. These are for your straight transverse fractures, usually 2-part fractures, which is either a direct trauma or they've been pulled apart. Now, the reason it's called tension banding, the whole principle is essentially there's eccentric load on the patella, and it's going, when the patella is fractured, it's going to try and get pulled apart from the tensile side, so the anterior part. And so the tension side is actually overwhelming the compression that's normally in place, because you've got quadriceps tendon pulling up, you've got patella tendon pulling down. So the idea is you put a tension band wire, and this is going to be applied to the tension side of the patella. And by doing so, what this does is you're neutralizing the tensile forces that are trying to pull the patella apart. Now, the way this is done, usually you can pass 2 1.6 mil K wires through the patella, and then you pass sort of an 18 gauge stainless steel wire that you can either do in a figure of, most people do a sort of figure of 8, some people do a direct circle, and then you can reinforce this with a circle arch wire if you're worried it might be a bit comminuted. You need to just reinforce the hold a bit better. The alternative is something that's coming up a bit more often, is using tension band suturing instead. So you can use sort of a 5 Ethibond or orthocord, and this is a bit less irritant to the skin, the soft tissue, although it obviously has a bit less tensile strength than a wire. If your fracture is a bit more comminuted, you might be thinking about sort of using mini plating, so try and bring those small bits back together again. There's some dedicated plating. I'll show you some pictures in a minute where it's a plate that can go over the entire patella and just fix into the different sections, sort of the VA, like the VA Synthes plate you can use. And the other thing is if the patient's got a really, really comminuted patella, it's completely smashed, it's in bits, and you can't salvage it, then you end up doing a patellectomy. The problem with that is obviously it's going to potentially lead to sort of extensor lag of the knee, which is not great, but sometimes what can you do? These are the options, some pictures of the main options. So on the top left hand of the screen, you've got tension band wiring with a circle arch wire all the way around. Over the far right side, you've got one, it's a patellectomy. You can see no patella in front of the kneecap, in front of the knee. And the other, you can also see sort of these mini frag plates that are sort of holding the different fragments together. And down the bottom, you've got this sort of custom patella plate that sort of has VA screws that goes in all directions to hold the different fragments. So let's try this again. We've got a 40-year-old gentleman this time, tripped and fell, landing directly on his left knee, normally no problems. Now he's got painful range of motion when actively asked to do so. He's got a bit of bruising over the front of his knee. It's a bit swollen. A&E has nicely ordered some AP and skyline views. What do you want to do for this patient? Let me bring up the question. Okay, have a look at that. See what you think. Okay, I'll pause it there. So yeah, that's interesting. So, 40% of you said they're fine, leave them alone, but actually some of you thought maybe tension band wiring, and some of you thought maybe let's lag it. Now, this is a funny thing. So it's not actually a patellar fracture, this one. So this is another condition you should be aware of, because sometimes you will get called by A&E about someone who's got this unusual x-ray. We think it's a broken bone. It's not. This is something called a bipartite patella. So it's essentially an anatomical variant. In 50% of patients who have it, it's bilateral. And it's actually a failure of the primary and secondary ossification centers to come together and form into a complete patella. Type 3, which is, if you see the top right-hand corner, the superlateral is the commonest. So if you see these pictures, the way you differentiate it from a patellar fracture is it's really nicely well corticated. It's not nice, smooth lines. And typically it's not painful. Obviously, this person just fell over. So their knee is painful. This is how it's incidentally picked up. But normally it's completely asymptomatic. If they do have any discomfort with it, it's simply rest them, give them some non-steroidals, maybe a bit of physio if they're symptomatic. There's rarely a need for any surgical intervention, but if sort of 6 months of conservative management doesn't settle it down, then maybe you might think about putting a lag screw through it. But I must say, I've never seen that happen. It's just something people have. It's not something you need to do anything about. Case 3, 35-year-old gentleman. He's fallen from a 3-meter ladder, landing on his feet. He's unable to weight bear since. His knee's swollen. It's very tender. He's brought in by ambulance. A primary surgery has already been done by the time you get there. There's no head injury, no loss of consciousness. He's otherwise fit and well and a non-smoker. So this is tibial plateau fractures. This is a major topic that comes up in knees. Essentially, it's a fracture involving the articular surface that's between the distal femur and the proximal tibia. Comes in 2 main flavors. One is the low energy impact, which is usually in old patients or really high BMI patients who their bones just cannot support them any longer. The other is high energy impact, young patients or sports related with axial loading. And these are the patients you really need to start worrying about. These are the ones who have a risk of compartment syndrome, open fractures, neurovascular injury, well, vascular injuries as such. Obviously, the menisci sit right on top of the tibial plateau, so there's a risk of meniscal tears. ACL injuries can also come along with them. So next question here. Let me just bring up the next poll. All right, have a look at that. Tell me, which side do you think normally breaks? What's more commonest in tibial plateau fractures? I'll pause it there. So yeah, so a bit of a split. Obviously, half of you think lateral, 40% think medial, and it could be both. No one thinks posterior, so that's good. Now, actually, lateral ones are actually more common. Now, there's a good reason why for that. Now, if I just come to the next slide, anatomy of the knee. You've got your distal femur, your proximal tibia with the patella on top, as we already know. Now, the main thing to note here is that the lateral condyle, the lateral tibial plateau, it sits a bit higher, but it is thinner. The medial side sits a bit lower. It's got this sort of concave shape, which we'll see on the x-rays in a minute. But it is pretty solid. It's much stronger than the other side. And these, when you get patients with medial plateau fractures, this tends to be high energy impact. So you start worrying about sort of other associated injuries that might have come with it. So the main thing you want to do, obviously, HLS approach, confirm it's an isolated injury. You need to document, you do a really careful neurovascular examination and document all your findings, primarily your superficial perineal, deep perineal, your tibial nerves. Check the sensations distally, check the pulses, check the warmth. If there's any suspicion, you really need to make sure this is documented very clearly. If you're worried about pulses, put a Doppler probe on it. Listen for those pulses. If you're still concerned, get an ABPI. If it's less than 0.9, you need to be worrying about vascular injury and things about CT angio. Worry about compartment syndrome, especially these high energy impact people. So poke the compartments, make sure they're not tense. Make sure you're checking passive movements. Are you getting increased pain out of proportion? Is it exacerbated by passive movement? Start worrying about compartment syndrome, but document if whatever your findings are. Open fractures can also occur, again, with these high energy impacts. If you see a wound, you're not sure, one thing you can try and do is a saline load test, which is essentially similar to aspirating a knee, but you infiltrate about 200 mils of normal saline, obviously in an aseptic technique, into the knee and see if any of it comes out to the wound. If it does, there is likely a connection between the open wound and the joint itself. I address any wounds you see, immobilize them in above knee back slab, give them analgesia and monitor them very closely for compartment syndrome, make sure everyone's aware they need to be monitoring for compartment syndrome. Investigations. Plain film radiographs are your best friend in this case. APs and laterals are the main things we're going to be looking at. So we're going to look at the APs and laterals in vision in a second, but the main thing that often crops up in your laterals, you're looking for the lipohemarthrosis. These are sometimes hard to see. This one's a very obvious one. You can see the really clear line here of blood that goes underneath with fat floating on top of this. You've got these really clear defined lines with a very sharp flat line, which can only indicate fluid. Checking for the congruity of the joint line and checking the width, which we're going to have a look at in a minute. CT is the other option, plus minus angio if you're worried about vascular injuries. These are good for both identifying all the fragments, identifying where's the articular steps, and also if you're worried about vascular injuries, angio is going to tell you there's patency of all the vessels. AP views. Now, there's a really extensive video that goes into this by the OrthoHub team, which I actually really recommend. So it was really good, but it goes over this a lot more. But the main things I look for in these plain film x-rays is firstly, comparing the two joint lines. So remember, the medial side normally sits a bit lower, and you're checking for that concave shape, the sort of dip like that, while the lateral side should sit a bit higher. As you can see on this one, the lateral side seems to sit a bit low. It's got this sort of line running down here that seems a bit lower. You can see that sort of articular line here. It looks slightly wider as well. So on the AP view, the femoral condyle should line up with the tibial, with the sides of the tibia there. And if it doesn't, if it looks like there's widening, then it again could indicate there's a tibial plateau there. Look, as I said, look for any obvious depressed segments and look for any obvious fracture lines, obviously. On the lateral view, as I said, you're looking for that lipohemarthrosis, looking for that clear line of fat floating on top of blood. The other things you're going to look for is, again, the way you identify the medial condyle is you want to see, does it have a concave shape to it? Because that's likely that one. And higher up from that, you should have the lateral. Now, in this one, you can see there's a line that should be flat, but it's sitting a bit lower, which would more likely point towards a lateral condyle fracture than a medial. And that essentially gives you a rough idea of what you're going to look for. But in order to delineate this further, you can get a CT scan. So CTs are great for this sort of injury. And a lot of people jump straight to getting CTs. And the reason for that is sometimes, even if an injury looks quite innocuous on plain film radiographs, because obviously you're only getting two plain pictures from the AP and lateral views, as you take slices through, and it's like this coronal here, you can see it looks, the first picture, not too, it doesn't look terrible if you saw it on plain film radiographs, but you look at these ones, it gets progressively worse. You can see a massive depressed chunk there, and that's not great. Schatzker classification. This is, the commonest classification you encounter for tibial plateaus. Some guy has written a really nice paper that got published, which gives a bit of a funny story for how to remember the Schatzker classification, which I think is great. So essentially it goes, step one, you've had a break. It all tells the story of a breakup, essentially. So you've had a split from your partner and you're alone. You're sitting outside your house. Lateral side, split. Funnily enough, you get a bit depressed as a result of that. So you've got a depressed segment as well as having the split. After that, the split's gone away. It's in the past. And now you're just depressed. That's not great either. So then you look at things from the other side. You go over to the other side of things. But it doesn't matter what's going on. That's the medial side. So you've gone from the lateral over to the medial side. Then, a bit more time passes. You think about things from both sides. That's the lateral and the medial side. And then the more you think about it, it all goes to hell and the whole thing breaks apart. That's an absolute disaster. And that's a Schatzker 6. Great paper. So quiz time. Let me bring up the poll. What does everyone think this one is based off that whip through? I know it's very quick, so. All right, we'll pause there. All right, bit of a mix. Very nice. So a lot of you recognize that things have gone over to the other side here. These things have gone over to this side on the medial side. Not everything starts outside, it goes inside. And this is your Schatzker 4. It's a medial. It doesn't matter whether it's a split or a depression. It's all on the medial side. You've got a Schatzker 4 fracture here. So that's great. Let's go on to the next question here. Oh, that's terrible. All right. So let's see the next poll. I mean, you already know what the question coming up is. Can I change this now? All right, what do you guys think this is? I'll pause it there. Exactly. I mean, you guys got it. It's an absolute disaster. Things are falling apart. You're falling apart. It's a Schatzker 6. It's a disaster. So everyone's going to be very depressed about this. All right. So whole Moore is another classification system. It's less common, but if you can bring it up in the trauma meeting when you're a junior reg, people are going to be quite impressed. It's applied for when you've got fracture dislocations that don't, or fractures that don't quite fit into the Schatzker classification. So 5 types: coronal splits, entire involvement of the condyle, a rim fracture of the lateral plateau, a rim compression fracture, and a 4-part fracture. It doesn't seem as snappy as the Schatzker classification, but some people use it when it doesn't fit with the Schatzker. Non-operative management. Now, there's obviously it can go either way with a lot of these fractures, but the general rules are if it's minimally displaced or undisplaced in your Schatzker 1 to 3, then you're all right, you can get away with it. If you've got a small middle depression, but there's no obvious deformity and there's no varus valgus instability, you can get away with it. The patient's not fit for surgery, obviously. They're not going to make it. And elderly patients with low function demands. Whatever you achieve with the knee, it's not going to change a whole lot. It's not worth putting them through the surgery. These patients, I'd non-weight bear them 8 to 12 weeks, put them in a cricket pad splint or a hinge knee brace. If you think about it, the actual range of movement is not compromised by the tibial plateau fracture. So you could put them in a hinge knee brace and start getting them doing some range of movement, or from the off, really. But some people like to immobilize them straight for a period of time before they get them moving. Operative intervention, operative indications. Obvious articular depression between 3 to 10 millimeters, or obviously anything worse. Condylar widening. So remember the alignment of your tibia and your femur condyles. If there's widening sort of beyond 3 to 5 mils, that's also an indication to fix because it's just going to collapse further and come apart. Varus and valgus instability more than 5 to 10 degrees. And your Schatzker 4 to 6 is generally need fixation because your if you think about your medial mal bears about sort of 60 to 75% of your load through your body. And if that's broken, the whole thing is going to collapse the more you weight bear on it. What's the aims of operating on these patients? You want to restore alignment. That's in the coronal sagittals planes, and you also want to correct any slope that's in the knees. That's sort of posterior slope. Restore condylar width. That's also you're going to want to squeeze it back together so it looks nice. Want to make sure the knee's stable. Sometimes this does involve subsequent soft tissue knee reconstruction and making sure there's a congruent articular surface. Don't do this. This is terrible. I found this on a funny Twitter account called Disasterplasty. It's great. Operative management, how are you going to go about fixing it? So the main approaches, the main workhorses for these fractures are your anterolateral and your posteromedial approaches. Check the AO trauma website if you want details on that. The main principles behind it, if there's a depressed segment you want to get in and you want to get sub-meniscal arthrotomy, you want to jack those depressed fragments up. If it's very comminuted, there's just dust, and you've got a large gap, you're going to need about putting bone grafts in to try and fill any large bony defects. But sometimes you've got a section that's fallen down as a chunk, and you've got a split coming out here when it widens. Those ones potentially you could jack up and then bring everything back together, and that's going to restore your articular surface. Some people, if there's a large split, so the widening's there, you want to get a large periarticular clamp, the ones that go all the way around like that, and squeeze, and that can push everything back together and squeeze it back into a nice width and restoring the articular surface is 1. And then you're going to want to hold it. Now, in your really minor ones, your minimally displaced sort of Schatzker 2-3s that you somehow ended up operating on, some people get away with just a few screws. But with these big ones, you're going to be putting buttress plating on, or you can do sort of these periarticular pre-contoured platings. You can supplement these with raft screws, which are these screws which essentially sit right in the subchondral bone and are essentially going to support the articular surface by lying right underneath them. And as I said, bone grafting for these large gaps. This is a case that came in to my hospital last week. So you can see here, there's a little tibial plateau fracture on the lateral aspect. So the main thing you can see here is there's a dropped line here with librohemarthrosis up here. There was a very large swelling here. 73-year-old lady who was fit enough for theatre. CT scan shows this depressed segment here. And this is what happened. So you can see on the far left, this was an osteotome used to jack up the depressed segment. It was held with K-wires, and then they put a large plate on the side here. And these screws are sort of acting like raft screws underneath. Some patients are not fit for definitive management straight away. This could be because they've got severe open fractures with a lot of contamination, it's severely comminuted, or there's a lot of soft tissue injury, swelling, or it's a polytrauma. You know, the patient's got a lot of things that are going on. You're thinking about sort of your damage control, orthopedic operating. So for these patients, you can either use one of these sort of joint spanning sort of unis or almost biplanar X-fixes, or the other option are these circular fixators as well, these circular frames, as you can see down on the right-hand side. And that's about it, really. So, I mean, there's obviously a few other knee conditions that come under sort of bony knee trauma, but these are the big ones that you keep coming across and you might be quizzed on as a junior trainee, as a junior registrar. They come from both low and high energy injuries. It's really important to identify whether this is just an isolated injury or whether it's part of a polytrauma, because that's going to change your management. And then you need to know what's your objective behind the operation that you're doing. What are you trying to achieve? And that's going to help you determine what you're going to use and how what your end result should look like by the end of it. Thank you.
Thank you very much, Seb, for a great talk. And now we've got Mr. Alex Charalambous, who will be talking about soft tissue knee injuries. And I'll hand it over to Mr. Charalambous.
Thank you very much. Thank you, Sebastian, for a great talk. Let me just share my screen. So soft tissue knee trauma is a pretty huge topic. Looking at and managing soft tissue knee injuries is something that we all will have kind of a variable exposure to throughout the stages of our training. Certainly in the acute setting, you may see multi-ligament knee injuries in the emergency department, but the majority of these will be seen in an outpatient department. So it's important to give yourself that exposure, try and get down to a knee clinic and try and get to as many arthroscopies or knee surgeries as possible to give you that understanding and exposure. The main areas we're going to cover today are going to be ACL meniscal injuries, because I think this will form the majority of things that you'll be exposed to early in your training. But we're also going to cover posterior cruciate and posterolateral corner as well. And we're going to achieve this by looking at the anatomy, a function of each ligament complex, a bit about the history and examination they're going to look for in each injury. And then we're going to touch on the key investigations and the treatment options for each one. So in terms of the anterior and posterior cruciates, you can see that they're visible in the femoral notch. The anterior is described because it's anterior in the notch, and the posterior is posterior in the notch. And you can see that they run obliquely and they cross over each other, hence the name cruciate. And the anterior cruciate arises from the anteromedial aspect of the tibial plateau and attaches to the lateral wall of the notch. And functionally and anatomically, it's kind of divided into two main bundles. And they are tensioned throughout slightly different stages of the knee movement. So you have the anteromedial bundle, which is predominantly tight when the knee is in flexion. And then you have the posterolateral bundle, which is predominantly tight when the knee is in extension. And as you can see from this depiction here, they kind of cross over each other as the knee moves from a range from extension into deep flexion. The blood supply to the ACL is predominantly from the middle genicular artery, so these injuries can bleed a lot, and the nerve supply is from branches of the tibial nerve. The main function of the ACL, it resists the anterior tibial translation, but it does have a role to play in some rotational stability as well. It's commonly injured with the typical sporting non-contact pivot injury, but also with direct blow to the knee, and is slightly more common in females than males due to anatomical and biomechanical differences. So when you see these patients, either in the emergency department or in clinic, ask them about their trauma. You want to know about the mechanism of their injury, and one important determining factor is the timing of their hemarthrosis. So an immediate hemarthrosis after any kind of knee injury is indicative of quite significant intra-articular injury. So ask them about this. And then importantly, to ascertain whether they're going to be a candidate for reconstruction, you want to ask about their instability. Do they have episodes of instability? How often? And is this dynamic instability only when they're moving or changing direction? Don't forget to ask about other mechanical symptoms, because these injuries often do not occur in isolation. And the key one here is not to miss a concurrent meniscal injury. So stick with your standard orthopedic algorithm of look, feel, move. The key thing here is assess for any associated injuries and do some special tests for the ACL. In this case, you're going to think about doing the anterior draw, a Lachman's test. So it's important to practice these in normal knees and pathological knees as much as possible. My favorite is the pivot shift test, but this can be quite challenging in a non-anesthetized patient. So it's something else which is often done as an examination under anesthetic. So try and get yourself to theatre to examine these knees when the patient is under a GA. In terms of imaging, there's always a role for plain X-rays in any kind of knee injury. This, as you can see here, can be quite innocuous and easy to miss. A small avulsion over the anterolateral aspect of the tibia, and this is described by Segond and is considered to be pathognomonic for an ACL injury. But certainly if you see something like this, you should ring an alarm bell that there might be an underlying soft tissue injury. The key here is to get MRI imaging. So this is often done as an outpatient, but you can see on the left side this T1 weighted sagittal image. The ACL should be running nicely from anterior to posterior, but there is a complete disruption in the fibers here. And the key thing that you're looking for on the coronal view on the right, which is a T2 weighted image in this occasion, is this kind of empty lateral notch. So the ACL should be running up and attaching into that part of the notch, but on this, all you can see is synovial fluid. The decision in terms of treatment is often going to be made in an outpatient clinic, but the primary indication for reconstruction is symptomatic instability. There is a role for conservative treatments such as bracing, activity modification, and targeted physiotherapy in quite a lot of patients. So it's always worth trialing this if you're not sure whether they'd be a good candidate for reconstruction. The surgical intervention of choice is going to be a reconstruction more commonly than repair. And in the majority of patients, you're going to wait until the knee effusion and inflammation is settled. This will reduce the risk of any post-operative arthrofibrosis. But in the elite sportsman setting, this is often done as quickly as possible. But I think the majority of our practice is best to wait till they have a good range of movement in the knee. There are several options in terms of reconstruction, several graft options: autograft, allograft, and synthetic grafts. The majority in the UK are autografts, and these are primarily hamstrings, but there are also a large proportion of patella or BTB and also quadriceps. It's done with standard anterolateral and anteromedial viewing portals with as many accessory portals as you need. The important thing is going to be your tunnel placement. So this can take some time to kind of triangulate the images that you're seeing on arthroscopy and getting the 3D anatomy in your brain. But getting the tunnels right is going to be the main factor to determine whether this is successful or whether it fails down the line. So there are several anatomical markers that we look for. The key ones that you're going to hear about are going to be on the tibial side, which is going to be the lateral meniscus anterior root attachment, or the LARA. So if you follow this round, you'll get to kind of the center of the footprint of the ACL on the tibia. And there are some nice anatomical markers on the lateral wall of the notch, which you want to identify. So the lateral intercondylar ridge marks the most anterior attachment of the ACL fibers, otherwise known as the residence ridge. And then you've also got the bifurcate ridge, which identifies the attachment of the different bundles within the ACL. You may see or hear people talk about the clock face, and this describes the view of the notch with the knee inflection. So there's been a move from a more 12 o'clock position to a more kind of 9-10 horizontal position, just to reduce the risk of any postoperative instability and rupture rate. But this again is something that you will only see once you're in the OR and you're looking at more and more of these cases. Postoperatively, you're going to try and mobilize these patients as quickly as possible. What you can see here from this X-ray are different type of fixation options that you have when you're doing the reconstruction. So you've got aperture fixation, which is commonly in the form of metallic or PEEK screws. And then you've got suspensory fixation, which is usually something like an endo button with suture attachment that you've sutured into your ACL graft. And there's some good further reading from the BOA and the BASC. And also there is a national ligament registry if you want to look further into graft options trends in the UK. Does anyone have any questions at this stage?
Alex, someone's asked if you could, did I miss this bit? Can you point out exactly where the second is? Did you do that already?
I don't know if you can see my arrow, but it's just here.
Perfect.
Thank you. And I think that was the only question so far.
So moving swiftly on to meniscal injuries, our anatomical drawing that we put up earlier is depicted anatomically on the right side, and you have the medial and lateral meniscus, and you can see that they're quite different in shape. The medial side is more C-shaped, and it's closely adherent to the medial capsule and the MCL. And as a result of that, it's far less mobile than the lateral meniscus, which is more horseshoe shaped. And you can see they have key root attachments anteriorly and posteriorly. And then you have the transversal anterior intermeniscal ligament at the front and posterior meniscal attachments at the back. As a result of the lateral side being more mobile, it's more commonly injured in acute knee injuries. When we look at a cross-section of the meniscus, they have a nice wedge shape, and they're relatively avascular structures. So you can see that they have blood supply from the periphery, from this perimeniscal capillary network, and it kind of radiates more inward. But as you get more towards the center of the meniscus, you have less and less of a good blood supply. And there are varying orientations of these collagen fibers within it as well. This becomes important when we think about whether they're going to be amenable to repair or not. They have several functions. They're important in load transmission, articular conformity, and synovial fluid distribution within the knee. But there's also some role in proprioception and AP stabilization, particularly in a ligament deficient knee. And they have a very similar injury mechanism to your cruciate ligament. So this kind of pivot injury, but also be aware of kind of the degenerative tear that may be present that you might read on an MRI report, for example. Again, ask the patient about the history of trauma, the mechanism of the injury. The key thing here is we want to know about their mechanical symptoms, this catching, locking, giving way, and this may mean that they require further treatment down the line. Palpate the joint line. It's one of the most sensitive markers for meniscal pathology. There are some provocative tests like McMurray's, Apley's, Thessaly's test, but be cautious. They can cause pain, and always ask the patient if they're comfortable with you doing that. And it might be something that you may not always do in the exam setting as well. Again, MRI is the imaging of choice. The best views are going to be your coronal and sagittal views with T2 weighted images. You can see on the left here the nice wedge cross section of the meniscus, and you can see this line running through it, which represents synovial fluid tracking through what's likely to be a horizontal tear in the posterior horn of that meniscus. And on the right side, we're looking at the notch here, and you may look at the PCL and wonder why there looks to be a second structure in front of it. So this is the double PCL sign, which is indicative of a displaced large bucket handle tear. So in this case, a large horizontal tear along the whole course of the meniscus has caused it to flip into the notch. So this is something also to look out for. You can classify the meniscal tears according to their location within the meniscus, so anterior horn, body, or posterior horn. And then you can also describe it according to how peripheral it is. So this touches on the blood supply earlier. So the red zone is going to be the most vascular area, is going to have the most ability to heal or repair itself. And the white zone in the center is going to have the least capacity for repair. And you can also describe the pattern of the meniscal tear as well, it being horizontal or radial, for example, or this bucket handle tear that we talked about earlier. You may see the acute locked knee on your on-calls in the emergency department. So this is someone who will have a mechanical block to the knee. Examine them with adequate analgesia on board. And if you do think it's a true locked knee, try and arrange a senior review or an urgent MRI as quickly as possible, because the quicker we get inside that knee, the meniscus may be more amenable to repair, and the quicker we get the knee moving. Some surgeons may even proceed directly to arthroscopy without doing an MRI scan, but I think that is relatively risky ground because many patients may present with a kind of pseudo-locked knee, and it may not be a true mechanical lock. The key factors are going to be the timing, the location of the tear, and the pattern of the tear that we spoke about earlier. Again, there is a role for conservative treatment, and surgeries either in the form of arthroscopic meniscal debridement or meniscal repair. And there are several techniques. You may have heard of all inside, inside out, or outside in. So the all inside is becoming more popular. It utilizes specific tools that allow you to place a suture with a small anchor directly from an arthroscopic portal, whereas the inside out or outside in involve passing a meniscal needle and suture actually through the meniscus and directly outside, so they require an incision on the outside of the knee. But they've got a good track record and still work. So the technique is ultimately determined by the location of the tear, the character of the tear, and the surgeon preference. So an anterior horn may be very difficult to get from an all-inside technique. So you may need to do something like an inside out or an outside in to catch that. But again, the more you see, the more you will understand as to why each technique is utilized. On the left side, you can see the kind of all-inside technique. And on the right side, you can see one company's special kind of meniscal needle for passing a suture from the inside out. In terms of number of anchors, this can vary in terms of the length of the tear and the location, but try and get at least 2, possibly 3 if you can across the tear. The key question is when are they amenable to repair? So try and repair a bucket handle if possible and it's acute, because you're going to preserve a lot of meniscal tissue. But the key factors are going to be location, time to repair. So the earlier you get to it, the better. Age is no longer considered a key factor, but meniscal degenerative change is. So the older you are, the more likely you are to have degenerative change and the less success you're going to have for the repair to take. And also BMI is also quite an important factor to consider as well. Again, there are good BAS guidelines to have a read through if you want to have a further read on meniscal tears. Any questions at this point on meniscal tears?
There is one question that someone's asked. How would you approach a multi-ligament meniscal and osteochondral injury in one knee?
So I think this is always controversial, and you'll ask different surgeons and they'll have different opinions. There is a fair body of evidence to suggest that a meniscal injury that is repaired at the time of a ligament injury has a greater chance of being successful. So I think the important thing is any bony osteochondral injury, repair that as soon as possible, and then get an appropriate time and appropriately trained surgeon to do the ligament reconstruction and try and do the meniscal repair at the same time. If you can do it all in one sitting, great, but you also have to think about graft options in the multi-ligament knee. So again, I would just take it on a patient-to-patient basis and what surgeons you have available at the time, if that answers the question without being too ambiguous.
Thank you. I think that's fine.
All right, we'll try and touch on some PCL and posterolateral corner. We've got probably about 7 or 8 minutes, hopefully. So PCL injury, PCL anatomy, we've talked about ACL, predominantly in the notch, as well as the PCL. And you can see here that it attaches to the kind of medial, anteromedial wall of the notch and arises from the posterior aspect of the tibia. So you have this kind of flare at the back of the tibia, what's sometimes described as the champagne glass drop-off. And really anything proximal to that, you're going into PCL attachment. Again, it's divided into 2 main bundles, anterolateral this time instead of anteromedial, and posteromedial. And you can look at the notch and you can see actually quite a clear difference between the different fibers on this anatomical specimen. Functionally, it acts as your primary restraint to posterior tibial translation, but it also does have a role to play in rotational stability. Commonly, you're going to see a PCL injury with a direct blow on the anterior aspect of the tibia, so your dashboard injury, but also common in sporting injuries. Hyperflexion with a plantar flex foot, and also hyperextension. So again, ask about the injury, and important to note here, PCL rarely occurs in isolation. In terms of examination here, you can see that on the right knee, there's quite a clear sag. So this should give you a clue that something's going on. Always check for this before you do your anterior draw as well, so you don't get a false positive. There are some other tests, quadriceps active test. You're asking the patient to activate their quads with their knee in a flex position, and you should see the tibia move anteriorly as you're kind of correcting the posterior sag. And also the dial test, which is done prone, and you're looking for a difference in external rotation. Important thing with any kind of PCL injury or multi-ligament injury is your neurovascular examination, and consider further imaging, even in the emergency department, in the form of a CT angio if you do see a PCL in the setting of multi-ligament or dislocation. Again, in terms of plain imaging, look for avulsion fractures. They're probably slightly more common on the PCL than the ACL. Excuse me. And again, MRI is going to be our key imaging of choice. And you can see here, compared to our previous sagittal views, a clear disruption in the PCL fibers. They should be running nicely from the notch to the posterior aspect of the tibia. Some authors advocate stress flexed view with the knee on some form of pad in the X-ray department. And again, you're looking for the posterior border of the tibia, and your anatomical marker here is Blumensatz's line, which is the marker of the notch radiologically. And you're looking as to whether this is going to be translated when you apply the load on the anterior tibia. You can generally classify them according to how much posterior sag there is on clinical examination. So anything kind of beyond 10 millimeters signifies a significant injury, possibly multi-ligament injury, and you're looking as to whether it lines up with the femoral condyles. The majority of PCL injuries can be treated non-operatively. Again, there's some controversy whether you immobilize the knee or not. I would say if you have a bony avulsion that you're treating non-operatively, it may be wise to limit the movement in the knee for a certain period of time. Otherwise, if you're treating a pure soft tissue injury, it may be useful to get the knee moving sooner rather than later. The main controversies or techniques in terms of PCL repair are a debate between single bundle, where you're recreating just the anterolateral bundle, or the double bundle repair. You're more commonly going to use allograft than an ACL. And there are techniques where you're doing a transtibial or a tibial inlay. So a transtibial technique, you're using drill holes similar to the ACL, whereas a tibial inlay, you're doing an actual open approach to the posterior tibia, and you're fixing your bone block with your graft to the tibia. Again, some good further reading here. And we'll move quickly on to posterolateral corner. This is a topic which confuses me at times, confuses a lot of people. It's complex anatomically. But the key thing to remember is there's three main structures that give you stability in the posterolateral corner. It's your lateral collateral, your popliteus tendon, and your popliteofibular ligament. You can look at all of the structures in the posterolateral corner, whether they be static or dynamic, and they all contribute to the stability of the knee. You can divide them into anatomical layers. The key thing here is to have an idea of this when you're doing your surgical approach, because you're going to come across key structures at each of the different layers, which you're going to want to identify. The main one being the common peroneal nerve between the most superficial layer and the second layer. And it also becomes important when you're going to be passing your grafts in the reconstruction stage. It has an important role in varus stability, but also in terms of posterior translation and external rotation. It works alongside the PCL. And it's important to note that isolated posterolateral corner injuries are rare. Missed posterolateral corner injuries are a very common cause of ACL reconstruction failure, and a fair proportion are associated with common peroneal nerve injury. So they're the main take-home messages, I think, from the posterolateral corner. Again, commonly is a blow to a flexed knee. So ask about the history of trauma and the mechanism of injury. The key thing here is to ask about their instability. And in terms of examination, you're going to look for a varus thrust or hyperextension when they're walking. And you're going to want to examine the knee for varus stress, both in extension and in 30 degrees of flexion. And don't forget the neurovascular examination. We talked about the dial test earlier. So you're putting the patient prone and you are looking for symmetry in external rotation at both of the feet, essentially. So anything more than about 10, 15 degrees of asymmetry, you should be suspicious of some kind of injury. You want to do the test at 30 degrees and at 90 degrees. So if you have asymmetry just at 30 degrees, you're looking at potentially a PCL alone injury. But if you have asymmetry throughout, then you should be suspicious of PLC as well. Look for fibular avulsion fractures on your X-ray. That can give you a clue to an underlying injury in the area. But again, MRI is the imaging of choice. You can grade it mild, moderate, or severe according to the degree of varus instability or varus opening you have. And treatment-wise, if you have a bony avulsion, they may be amenable to acute reconstruction, but the majority of these, again, there is a role for non-operative management in grade 1, grade 2, but reconstruction should be a patient-specific decision. You should consider it in grade 3 injuries, and any multi-ligament injury, you should be looking to reconstruct the posterolateral corner. There's a high failure rate for repairs of over 40% if there's no bony involvement. So perhaps consider this only if you have those fibular avulsion fractures. There are several techniques described for reconstructive options, but generally they all involve a lateral curved incision. And the key factor is to identify the common peroneal nerve, release it and protect it. And you're going to reconstruct it as best you can, isometrically and anatomically. Different techniques are the Larson technique that you may hear about, the double bundle technique, or the technique described by Leprade. I won't go into them in too much detail, but you can read about them more if you want to. And there's a good current concept review again for posterolateral corner injuries for further reading if you would like to do that. Thank you very much. A lot to cover, fairly didactic. I'm sorry about that, but hopefully you got some key things to look for each one.
Thank you very much. We just have one question. Is there any particular reason why allograft is used more commonly in PCL than ACL repair?
I don't have a huge amount of experience with PCL, but my understanding is if you're using the transtibial drilling technique, you need a longer graft than you may need in the ACL. So it just gives you that option in terms of graft length. And also because it's often done in the setting of a multi-ligament knee, you may want to preserve the hamstrings for elsewhere.
Thank you. Thank you very much, Mr. Charalambous, on the soft tissue